The scream came first. Then the grinding sound of concrete and steel compressing flesh and bone. Then silence. The kind of silence that precedes a decision that will define whether a man keeps his arm or loses it in the next 6 hours. March 1945. A field hospital 17 kilometers behind American lines in the Rhineland. The temperature outside was 2 degrees Celsius. Inside the tent, barely warmer. And in that tent, a 23-year-old American nurse named Dorothy Harmon was about to do something that would violate every piece of medical training she had received, contradict the advice of 2 surgeons, and save the arm of a man who, 3 weeks earlier, had been trying to kill American soldiers. This is the story of a German prisoner, a crushed limb, and a bag of ice. But it is really about the moment when compassion collided with protocol, when a nurse trusted observation over authority, and when the enemy became simply a young man screaming in a language she did not understand. And what it reveals about the space between doctrine and innovation, about how breakthroughs often come from those with the least institutional power, and about the strange mercy that sometimes emerges in the wreckage of total war. To understand what Dorothy Harmon did in that tent and why it mattered, you first need to understand what everyone believed about crush injuries in 1945. They believed that when a limb was compressed severely, when muscle tissue was pulverized and blood flow was compromised, the countdown to amputation began immediately. This was not conjecture. This was medical consensus, built on centuries of battlefield experience and reinforced by every surgery manual in every field hospital in Europe. They believed that swelling was the enemy. That circulation had to be restored through warmth and elevation. That ice, if used at all, was for superficial wounds, minor sprains, nothing serious. They believed that when a German artillery position took a direct hit and the makeshift bunker collapsed on the soldiers inside, when one of those soldiers was pulled from the rubble with his right arm compressed from shoulder to fingertips, crushed so severely that bone fragments were visible through torn skin, the trajectory was inevitable. Triage, morphine, amputation within hours, maybe a day if you were lucky, and the infection did not set in first. This was not cruelty. This was medicine. The calculus was simple. A crushed limb meant massive internal bleeding, meant toxins building up in dying tissue, meant the choice between losing the arm or losing the patient. Every doctor in that hospital had made that calculation dozens of times. Every nurse had assisted in those amputations, had held the hands of young men as they woke up to discover they were no longer whole. The protocol was clear. The outcomes were predictable. And then Dorothy Harmon looked at the German soldier they brought in on March 14, 1945, and decided that everything she had been taught was wrong. His name was Klaus Becker, 20 years old, drafted into the Wehrmacht at 17, part of an artillery unit that had been shelling American positions for 3 days before the counterattack came. When the American shells found their position, Becker had been inside the makeshift bunker, essentially a reinforced hole covered with logs, sandbags, and desperation. The first shell collapsed the eastern wall. The second brought down the ceiling. Becker's arm was pinned under approximately 200 kilograms of concrete debris mixed with splintered wood and frozen earth. His squadmates were killed instantly. He was not. For 40 minutes, he remained trapped, conscious, feeling the weight compress his arm, feeling the circulation stop, feeling the tissue begin to die. When American infantry secured the position, they found him still alive, barely. They pulled him out. Standard protocol. Enemy wounded were treated the same as American wounded, at least in theory. The reality was more complicated, more dependent on individual decisions made by exhausted medics in the chaos of advancement. Becker was lucky. The medic who found him, Corporal James Rivera, was the kind of man who saw a screaming kid before he saw an enemy combatant. Rivera administered morphine, applied a tourniquet, and called for evacuation. 2 hours later, Becker was in the field hospital. His arm was unrecognizable, swollen to twice its normal size, skin mottled purple and black, bone fragments pressing against tissue. The radial pulse was absent. When you cannot find a pulse, when the limb is cold and the color is wrong, the diagnosis is obvious. This arm was dying. The only question was whether they would amputate now or wait for gangrene to make the decision for them. Dorothy Harmon was from Cedar Rapids, Iowa. Daughter of a pharmacist and a schoolteacher, she had graduated from nursing school in 1942, enlisted in the Army Nurse Corps in 1943, and shipped to England in early 1944. She had seen D-Day casualties. She had worked through the brutality of the Hurtgen Forest. She had held intestines inside abdominal cavities while surgeons worked. She had written letters to mothers explaining that their sons died quickly, painlessly. Even when that was a lie designed to provide comfort, she herself did not feel. She was not naive. She was not idealistic in any romantic sense. She was exhausted, traumatized, and very, very good at her job. But there was something else about Harmon that the other nurses had noticed. She watched. While other nurses followed protocol automatically, efficiently, Harmon observed. She noticed patterns. She asked questions that seemed irrelevant until they were not. She had a habit of challenging doctors, not with hostility but with a quiet persistence that wore down resistance. Some doctors appreciated it. Others found it irritating. All of them respected her, because when Harmon questioned something, she was usually right. When they brought Becker into the surgical tent, 2 surgeons examined him within minutes. Captain David Chen, a 34-year-old orthopedic surgeon from San Francisco, and Major Robert Fitzgerald, 41, a general surgeon from Boston who had been operating since the North Africa campaign. Both men reached the same conclusion immediately: amputation, probably at the shoulder to ensure they removed all the dead tissue. They gave Becker 6 hours, time enough to stabilize him, confirm the extent of the damage, and prepare the operating theater. Harmon was assigned to monitor him during those 6 hours, keep him comfortable, keep him alive, prepare him for the loss of his arm. She spoke no German, he spoke no English, but pain is a universal language, and so is terror. Becker knew what was coming. You could see it in his eyes. The morphine dulled the pain, but not the understanding. He kept looking at his arm, then at Harmon, then back at his arm, asking a question with his eyes that she could not answer. She checked his vitals every 20 minutes. Pulse steady but weak, blood pressure low but stable, temperature slightly elevated, early sign of infection setting in. The arm continued to swell. This was expected. This was why they were going to amputate. And then Harmon noticed something that did not fit the pattern. The swelling was progressing, yes, but it was not uniform. The tissue closest to the site of the crush injury was massively swollen, grotesquely distended. But the areas farther from the impact point, the forearm and hand, were swelling more slowly, almost as if the body was trying to compartmentalize the damage, trying to keep the destruction localized. This should not have meant anything. Swelling was swelling. But Harmon kept watching. She noticed that when she elevated the arm, the swelling in the hand decreased slightly. Not much, but measurably. She noticed that the areas with the most swelling were the warmest to the touch, almost hot despite the cold air in the tent. And she remembered something, not from her nursing training, from her childhood. Her brother had been a hockey player, minor league, never made it professionally, but serious enough. She remembered him coming home after games with his knee swollen, his ankle ballooned, his shoulder screaming. And she remembered her father, the pharmacist, with his obsessive reading of medical journals, telling her brother to use ice, not heat, ice, reduce the swelling, reduce the inflammation, give the tissue a chance to survive. Her instructors at nursing school had taught the opposite: warmth for circulation, ice only for minor injuries. But her father had ignored that. And her brother's injuries had healed faster than his teammates' injuries. She had noticed that. She always noticed. Harmon walked to the supply area and found Captain Chen. She asked him a question that must have seemed absurd. What if we tried cold compression instead of warmth and elevation? Chen looked at her as if she had suggested treating the injury with prayer and optimism. Cold would reduce circulation even further. The tissue was already starving for oxygen. Cutting off more blood flow would accelerate the death of the limb, not prevent it. This was basic physiology. This was not debatable. Harmon explained what she had observed: the localized heat, the differential swelling. Her theory that the heat was not healing, it was inflammation, and the inflammation was spreading the damage. Chen listened because he respected Harmon, but his answer was firm. No, the protocol was warmth and elevation until surgery. Deviating from that protocol could kill the patient or guarantee the loss of the limb. He was not being cruel. He was being a doctor, following the accumulated wisdom of military medicine. Harmon thanked him and walked back to Becca. She checked his vitals again. The swelling had increased. The skin was beginning to split in places. The pressure too great for the tissue to contain. In 3 hours they would take him to surgery. In 4 hours he would wake up without his arm. She made a decision that could have ended her career. She went outside the tent. March in the Rhineland. Cold enough that your breath crystallized. Cold enough that water left in canteens overnight turned to ice. She found a metal basin. She filled it with snow. She carried it inside. She positioned Becca's arm over the basin, and she began packing ice around the crushed tissue. Not everywhere. Just the areas with the most severe swelling, the areas that were hot to the touch. She worked carefully, methodically. She used cloth barriers to prevent frostbite. She monitored the skin color obsessively. She was violating direct orders from a superior officer. She was experimenting on a patient without consent. Not that Becca could have given informed consent, even if he understood what she was doing. She was risking his life based on a childhood memory and a hunch. This is how innovation happens in war. Not in laboratories, not in research hospitals with ethics committees and controlled trials. Intense, by exhausted nurses, making decisions that could save a life or end it. Harmon did not think of herself as innovative. She thought of herself as desperate and possibly insane. The first 30 minutes, nothing changed. The arm remained swollen. Becca remained sedated. Harmon remained terrified that she had just guaranteed his death. Then, at the 45-minute mark, she noticed the skin temperature dropping. Not everywhere, just where the ice was concentrated. The mottled purple was still there, but the angry red inflammation around the edges was fading slightly. She checked the pulse, still absent. She checked the capillary refill in his fingertips, still poor. But the swelling, the catastrophic ballooning that had been progressing steadily since his arrival, had stopped increasing. It had plateaued. Harmon did not celebrate. She did not even allow herself hope. She just continued. Replace the ice as it melted. Monitor the skin. Watch for signs of frostbite. Watch for signs that she was killing him. At the 90-minute mark, Major Fitzgerald came to check on the patient before surgery. He saw the ice. His reaction was immediate and volcanic. What the hell was she doing? Did she understand that she was destroying what little circulation remained? Did she want to be responsible for killing a prisoner of war? Harmon did not argue. She simply showed him the arm, showed him that the swelling had stabilized, showed him the temperature differential, asked him to feel the tissue. Fitzgerald was furious, but he was also a good doctor, which meant he was capable of changing his mind when confronted with evidence. He felt the arm. He measured the circumference at 3 points. He compared it to the measurements taken 90 minutes earlier. The swelling had not just stopped, it had decreased slightly. Impossible, except it was happening. Fitzgerald called for Chen. Both surgeons examined Becca together. They conferred in low voices. They checked and rechecked. They were witnessing something that contradicted their training, their experience, their understanding of how damaged tissue behaves. Chen asked Harmon to explain her reasoning. She did, haltingly, uncertain. She talked about localized inflammation, about the possibility that heat was a symptom of destruction, not healing, about the theory that reducing the inflammatory response might give the tissue a chance to survive. It was not sophisticated medical theory. It was observational logic from someone who did not have the institutional authority to be wrong. Chen and Fitzgerald made a decision that took remarkable intellectual flexibility. They decided to wait, not 6 hours, 24 hours. They would continue Harmon's ice compression protocol. They would monitor obsessively. And if the arm deteriorated, if infection set in, if the tissue continued to die, they would amputate immediately. But they would give it 24 hours. This was not protocol. This was two exhausted surgeons deciding that maybe, just maybe, the nurse was seeing something they had missed. The next 24 hours were a study in obsessive observation. Harmon did not sleep. She could not. Every 2 hours, she replaced the ice. Every 30 minutes, she checked circulation. She measured swelling. She monitored skin color. She watched for signs of infection, signs of necrosis, signs that her experiment was failing. Becker drifted in and out of consciousness. When he was awake, he watched her with an expression that was difficult to interpret: confusion, gratitude, fear. He did not understand what she was doing, but he understood that she was doing something, that she was fighting for his arm when everyone else had already decided it was lost. Other nurses rotated through. Some helped. Some thought Harmon had lost her mind. Captain Willis, the head surgical nurse, a woman who had been operating in combat zones since 1942, told Harmon directly that she was wasting time and resources on an enemy soldier who was going to lose his arm anyway. Why delay the inevitable? Why torture him with false hope? Harmon did not have a good answer to that. She just kept packing ice. At the 12-hour mark, something changed. Chen came to examine Becker again. He checked the radial pulse, and he found it. Faint, barely palpable, but present. A pulse meant circulation. Circulation meant living tissue. Living tissue meant possibility. Chen said nothing. He just looked at Harmon. She looked back. Neither of them spoke. What was there to say? They were in uncharted territory. At the 18-hour mark, the swelling had decreased measurably. Not dramatically, but enough that Becker's fingers, which had been sausage-like and immobile, could now flex slightly. Becker tested this himself when he was awake. Moving his fingers with an expression of shocked disbelief, he looked at Harmon. He said something in German. She did not understand the words, but she understood the meaning. Thank you. At the 24-hour mark, Fitzgerald and Chen conducted a full examination. They tested sensation. Becker could feel pressure in his fingertips. They tested motor function. He could move his thumb, his index finger. The movement was weak, painful, but present. They examined the wound site. The bone fragments were still there. The skin was still torn, but the tissue was pink, not black. Pink meant blood flow. Blood flow meant life. Fitzgerald made the call. No amputation, not yet. They would continue the ice compression for another 48 hours. They would start antibiotics to prevent infection. They would surgically clean the wound, remove the bone fragments, and see if the tissue continued to recover. This was not a guaranteed save. Becker could still lose the arm. Infection could still set in. But for the first time since he arrived, amputation was not inevitable. It was possible that he would keep his arm. And if he kept his arm, it was because a nurse from Iowa decided that protocol was less important than observation. 3 days later, they took Becker to surgery. Not for amputation, for reconstruction. They removed the shattered fragments of his radius. They debrided the necrotic tissue. They repaired what could be repaired. The surgery took 4 hours. When it was done, Becker still had his arm. It was damaged. It would never be fully functional, but it was his. He would wake up whole, or at least more whole than he had any right to expect. Now we need to slow down and understand something about medical knowledge and how it evolves. In 1945, the use of ice for acute trauma was considered fringe at best, dangerous at worst. The prevailing theory was that injured tissue needed warmth to promote circulation and healing. This was not stupid. This was based on centuries of observation that cold reduced blood flow, and that reduced blood flow led to tissue death. The problem was that this observation was incomplete. It did not account for the role of inflammation in acute crush injuries. It did not distinguish between the healing blood flow that repairs tissue and the inflammatory blood flow that spreads damage. Harmon did not have the vocabulary to explain this. She did not understand the biochemistry of inflammatory mediators or the mechanics of compartment syndrome. But she understood cause and effect. She saw that the heat in Becker's arm was not the heat of healing. It was the heat of destruction. And she intuited that reducing that heat might reduce the destruction. This is the gap between institutional knowledge and individual observation. Institutions accumulate wisdom slowly, carefully, through controlled processes. Individuals notice anomalies, trust their instincts, and sometimes stumble onto truths that institutions will take decades to validate. What Harmon discovered in that tent would not be formally recognized by military medicine for another 15 years. It was not until the late 1950s that studies began to document the benefits of cold compression for acute trauma. Not until the 1960s that RICE, rest, ice, compression, elevation became standard first aid protocol. Not until the 1970s that the mechanisms were fully understood, that doctors could explain why Harmon's instinct had been correct. By that time, thousands of limbs had been saved using techniques that built on the foundation she laid. But in March 1945, she was alone. She was a 23-year-old nurse with no research, no institutional support, no authority beyond her own conviction. And she saved a man's arm because she was willing to be wrong in a very public, very dangerous way. Think about the weight of that decision. She was not just risking Becker's life, she was risking her career. If Becker had died because of her intervention, or if the arm had died, or if infection had set in and killed him, she would have been held responsible. She could have been court-martialed for disobeying direct medical orders. She could have been sent home in disgrace. And all of that risk for a German soldier, for the enemy. This was not just medical innovation, this was moral courage. The question that haunted some of the other medical staff was simple. Why? Why take that risk for a German soldier? Why not just follow protocol? Let the surgeons amputate, move on to the next patient. There were American soldiers in that hospital who needed care, men who had been fighting for liberation, not conquest. Why spend resources, time and career capital on a man who had been shelling American positions 3 days earlier? Harmon never answered that question directly, but her actions suggested an answer. She did not see a German soldier. She saw a 20-year-old kid screaming in a language she did not understand. She saw someone's son, someone's brother, someone who did not choose the war any more than the American soldiers bleeding in the next tent had chosen it. This is the strange mercy that sometimes emerges in war, the recognition that the enemy is not an abstraction. The enemy is a human being in unimaginable pain, and if you have the skill to reduce that pain, the nationality becomes irrelevant. Not everyone felt this way. Some nurses and doctors treated German prisoners with cold efficiency, doing the minimum required by the Geneva Conventions and nothing more. Some treated them with open hostility. Harmon treated Becker the same way she would have treated an American soldier, not because she was a saint, but because she could not look at a crushed arm and see anything other than a medical problem that needed solving. Becker remained in the field hospital for 3 weeks. The arm healed slowly. Infection threatened twice but was controlled with antibiotics. Physical therapy began almost immediately, painful sessions where Becker had to force his damaged muscles to remember how to move. Harmon was not assigned to his ongoing care. She had other patients, other crises. But she checked on him when she could. They developed a strange, limited communication. He learned a few words of English. Thank you. Arm. Good. She learned a few words of German. Danke. Schmerz. Pain. Besser. Better. These tiny vocabulary exchanges felt absurd given the context, but they were also profoundly human. Two people from countries at war finding a way to communicate across the gap of language and ideology. 3 weeks after his surgery, Becker was transferred to a POW camp. Before he left, he asked to see Harmon. Through a translator, he told her that he understood what she had done, that she had saved not just his arm but his future, that he did not know how to repay that. Harmon told him, through the same translator, that he did not owe her anything, that she had done her job, that she hoped he would go home and live a life that made the arm worth saving. They shook hands, left hand to left hand, because his right hand was still too damaged, and then he was gone. Harmon never saw him again. She did not know what happened to him after the war. She did not know if he survived the POW camp. She did not know if the arm continued to function or if it eventually had to be amputated despite her efforts. She did not know if he returned to Germany, if he married, if he had children, if he told them about the American nurse who refused to let him lose his arm. She never knew. And for 40 years she did not talk about it, not because she was ashamed, but because it felt private, because in the chaos and horror of that field hospital, that one small victory felt like it belonged to Becker, not to her. It was not until 1985, when a historian researching battlefield medicine interviewed her for a project on the Army Nurse Corps, that the story came out. Even then, Harmon downplayed her role. She insisted that any competent nurse would have done the same. She insisted that the real heroes were the surgeons who trusted her judgment. She insisted that she had simply gotten lucky. The historian did not believe that. The historian recognized what Harman could not or would not see. That luck is not the same as observation. That trust is not the same as courage. That Harman had seen something everyone else missed and had risked everything to act on it. The implications of what Harman did extend far beyond one German soldier's arm. Her use of cold compression in acute trauma became, decades later, standard protocol for sports injuries, industrial accidents, battlefield wounds, any situation where tissue damage and inflammation needed to be controlled immediately. Rice became one of the most widely taught first aid techniques in the world. Millions of people avoided surgery, avoided amputation, avoided permanent disability because a 23-year-old nurse in a field hospital decided to trust her observations over institutional doctrine. She did not receive a medal for this. She was not promoted. She was not written up in medical journals in 1945. Her innovation was too quiet, too individual, too far from the centers of institutional power to be recognized in real time. This is how progress often works, not through dramatic breakthroughs announced in journals and rewarded with accolades, but through small acts of defiance, through individuals who see a problem and solve it, and then move on to the next problem without stopping to document their genius. The recognition comes later, if it comes at all, and often it comes too late for the innovator to benefit from it. There is another layer to this story that deserves examination: the moral complexity of providing care to enemy combatants. Becker was not an innocent. He was part of an artillery unit. Artillery kills from a distance impersonally, but it kills. The shells his unit fired killed American soldiers. If those shells had been more accurate, if the American counterattack had been slower, Becker might have killed dozens more. He was not a concentration camp guard. There is no evidence he committed war crimes, but he was a soldier in the Wehrmacht, an institution complicit in atrocities even if individual soldiers were not personally involved. So the question becomes, what does someone like Becker deserve? Does he deserve to lose his arm as punishment for fighting on the wrong side? Does he deserve compassion despite his role? Does morality require that we treat enemies differently than allies? Harman never expressed ambivalence about this. As far as she was concerned, once Becker became a patient, his nationality was irrelevant. This was not politics. This was medicine. But not everyone agreed. Some medical staff felt that prioritizing care for German prisoners was a betrayal of American soldiers, that resources were limited, that every minute spent on Becker was a minute not spent on someone who deserved it more. This tension existed throughout the war, and there was no easy answer to it. The Geneva Conventions require that prisoners of war receive medical care equivalent to what a captor nation provides its own soldiers. In theory, this meant Becker should have received the same treatment as an American soldier with a comparable injury. In practice, enforcement was inconsistent. Some hospitals followed the conventions meticulously. Some did not. Some provided care but with lower priority, so German prisoners waited longer, received less attention, had worse outcomes. Harman's hospital was relatively good about this. The command staff took the conventions seriously. But even in hospitals with good intentions, biases existed, conscious and unconscious. Soldiers who spoke English received better care because communication was easier. Soldiers who seemed cooperative, who seemed remorseful, received more compassionate treatment. Soldiers who were defiant, who clung to Nazi ideology even in defeat, were treated with cold professionalism. Becker was lucky in multiple ways. He was young. He seemed more frightened than ideological. He did not resist. And he ended up under the care of a nurse who did not see a German. She saw a crushed arm. That combination of factors saved him. If any one of those factors had been different, he would have lost his arm, or his life. After the war, Harman returned to Iowa. She worked as a civilian nurse for 30 years. She married. She had 3 children. She lived a life that from the outside looked unremarkable. But people who knew her well said she carried the war with her in ways she never fully articulated. She had nightmares. She could not watch war movies. She donated to organizations that provided prosthetics to veterans, American and foreign. She volunteered at veterans' hospitals. She never sought recognition for what she had done. When the historian interviewed her in 1985, When the story of Becker finally became public, she received letters. Some were from nurses who said her story inspired them. Some were from doctors who said they had started using cold compression because of her. Some were from veterans who said they wished they had been treated by someone like her. And one letter was from Germany. It was from a man named Klaus Becker. He had read about the interview in a German newspaper. He wanted her to know that he was alive, that he had returned to Germany in 1946, that he had worked as a mechanic, which he could do because he had 2 hands, that he had married and had 4 children, that his arm still worked, not perfectly but enough, that he had spent 40 years wondering if he would ever be able to thank her, that he was thanking her now. Harman kept that letter. She framed it, and when she died in 1998 at the age of 76, that letter was found among her most treasured possessions. Her children donated her papers to the Army Nurse Corps archives. Researchers studying battlefield medicine found her notes, her observations, her documentation of the ice compression technique. Those notes have been used in military medical training. The story of Klaus Becker and Dorothy Harman is now taught at the Army Medical Department Center and School as an example of innovative thinking under pressure. It is taught not just as medical history, but as ethics education, as a case study in what it means to treat patients as human beings rather than as nationals or enemies, as a reminder that sometimes the most important breakthroughs come from the least powerful people in the room, as evidence that progress requires the courage to question authority, the willingness to be wrong, and the compassion to care even when caring is complicated. So what does this story reveal about humanity, about war, about the nature of medical innovation and moral courage? It reveals something uncomfortable. That institutional knowledge, for all its value, can become institutional blindness. That protocols exist for good reasons, but can also prevent us from seeing what is directly in front of us. That the people with the most expertise are sometimes the least able to see beyond that expertise. It reveals that innovation often comes from the margins, from people who lack the authority to be wrong, so they have to be right, from people who are not invested in defending the existing system because they did not create it, from people who trust their observations over their training because their training has not yet calcified into dogma. It reveals something about the psychology of wartime care, that it is easier to follow protocol than to deviate, that deviating requires not just intelligence, but courage, because the cost of being wrong is catastrophic. That Harman did not save Becker's arm through superior knowledge. She saved it through superior observation, and the willingness to act on that observation, despite every institutional force telling her not to. It reveals something about the strange moral arithmetic of war, that we can kill someone at a distance with moral certainty, but once they become a patient, once they are wounded and helpless, something shifts. Not for everyone, but for some. For people like Harman, the enemy becomes a person, and once that transformation happens, the only ethical choice is to provide care. Not because the enemy deserves it in some cosmic sense, but because the act of providing care is what defines us as healers, as humans, as something other than the war machine that produced the injury in the first place. And it reveals something about the gap between recognition and impact, that Harman's innovation saved thousands of limbs over the next half-century, that her name is known to almost no one outside military medical circles, that she died without ever fully understanding the magnitude of what she had done, that this is normal, that most of the people who change the world do so quietly, without fanfare, without even realizing they have done something extraordinary. That history is made not just by the famous, but by the anonymous, by nurses packing ice in tents, by soldiers pulling enemies from rubble, by individuals making split-second decisions that ripple forward through time in ways they will never see. Klaus Becker died in 2003. He was 78 years old. He had lived 58 years longer than he would have if Dorothy Harman had followed protocol. He had worked for 40 years as a mechanic, raised 4 children, seen grandchildren born. He had lived through the reconstruction of Germany. He had seen his country transform from a fascist nightmare into a democracy. He had voted in elections. He had paid taxes. He had contributed to society. He had been by all accounts a decent man who did decent things. And all of that, every moment of those 58 years, existed because a nurse he could not speak to decided that his arm was worth fighting for. When he died, his family found among his possessions a photograph. It was not a photograph of Dorothy Harmon. He never had one. It was a photograph of his own arm, his right arm, taken in 1946, a year after the war ended. The scars were still visible, the damage was still obvious. But the arm was there, functional, his. And on the back of that photograph, in handwriting that had become shaky with age, he had written a single sentence in German. Sie hat mir mein Leben zurückgegeben. She gave me my life back. That is the story of a German soldier, a crushed arm and a bag of ice. But it is really the story of the moment when observation trumped doctrine, when compassion violated protocol, and when one person's willingness to be wrong in public saved a life that everyone else had already written off. It is the story of how progress happens, not through committees, not through formal research, but through individuals who see clearly, who act courageously, and who trust themselves even when every authority figure in the room is telling them they are making a mistake. It is the story of what happens when you refuse to accept that amputation is inevitable, that the enemy is irredeemable, that protocols are infallible. It is the story of a nurse who looked at a dying arm and decided that death was not acceptable. And in making that decision, in packing ice around crushed tissue in a freezing tent in the Rhineland in March of 1945, she changed the future. Not just for Klaus Becker, but for millions of people who would benefit from the technique she pioneered. People who do not know her name, people who will never know her name, people who walk on two legs, work with two hands, live full lives, because somewhere, decades ago, someone decided that institutional wisdom was less important than individual observation. That is Dorothy Harmon's legacy. Not fame, not recognition, but countless strangers living better lives because she trusted herself enough to pack ice around an arm that everyone else had already given up on. And if that is not heroism, then the word has no meaning.